Thank you, Cha. Welcome, everyone. Good evening and good morning to some, and probably good afternoon also for few of you. And most of us here in this region, it's good evening, sort of. And I would like to introduce the speaker for today's webinar. She is Ms. Lucy, and she's the Director for Digital Transformation at Novartis Foundation. And she will be talking to us about the Broadband Commission's report on virtual health and care that was released recently in June. And Ehin was also one of the contributors. A lot of work has gone over almost an year with a variety of institutions, and including some of the countries have contributed to that. And then she will be actually sharing the key highlights from the reports. And then we also have a panel of experts here, mostly the representatives from the countries. And then we have Dr. Fazila, who is the Senior Deputy Director of the Planning Division in the Ministry of Health, Malaysia. And then we also have Dr. Eric Teak. He's the Director for Knowledge Management and Information Technology Services in Department of Health, Philippines. And then we have Dr. Sanjay Sood, who is the Project Director for eSanjeevani National Telemedicine Service. And then he's based in the Center for Development of Advanced Computing, that's part of the Ministry of Electronics Information Technology in the government. And then we also have Dr. Narendra Kanal from Nepal, and he's the Chief of Hospital Service Strengthening and Management Section. And then he's also the head of the telemedicine division as part of curative services in the Department of Health Services, Ministry of Health and Population, Nepal. And we have Mr. Chen Wang Li Chi, and he is the Assistant Director for Regulatory Strategy and Transformation at Ministry of Health, Singapore. And then we also have Mr. Patota Tembonan, and he is the head of Ecosystem Tribe Digital Transformation Office, part of the Ministry of Health in Indonesia. And we have Dr. Fatima Khatun, and then she's an associate scientist and facilitator for digital health and health information systems based at ICDDRB, Bangladesh. So these are our distinguished panelists today. And then after the brief presentation on the reports by Ms. Lucy, and we will have this interactive conversation with the panelists here. And then we also plan to take few questions from the audience. And then now over to you, Lucy. Thank you.
Thank you so much, Jay, and thank you for the warm invitation from our friends from AHA. And it really means a lot to be here today and have the opportunity to present a little bit of the story behind the latest report touching about the lives of pretty much each one of us, I would say. So as we started saying, in the many years in which the HNIN has been one of really the key contributors to the working group on health within the Broadband Commission, we have seen the evolution really of the different topics. As you know, many years ago when we started within the Novartis Foundation, being part of this working group as well, the conversation was really around the role of digital tools for non-communicable diseases. Over time, it evolved towards the latest report, which was from last year, dedicated on the role of artificial intelligence in health. And this year, actually, together with your help and the whole actually working group on virtual health and care, we jointly created the latest piece of work, which we're going to be talking about today. And I hope that we have more of an active discussion. So I'm going to spend very little time on the actual highlights so that we can actually talk about what are some of the useful parts of this report and how we can apply those. But the key part is that the Novartis Foundation and WHO, with all your helps, created really an overview, or rather, I would say a best practice, if you want, handbook almost, of which are the right kind of definitions, which we all agree on in terms of what actually is virtual health and care. How does this actually impact the policy landscape, especially in the middle of a pandemic? Because this report was created exactly in parallel to the whole pandemic during the last 2 years. And so it was extremely timely. And in fact, the pandemic accelerated these discussions and in a way helped create these definitions. Now, there were a lot of definitions as to what exactly do we call virtual health and care. And really what came out of really the discussions within the working group that we all agreed that this is really about the delivery, the remote delivery of health and care services through digital means and technologies. Now, if you look at the distant parts within this definition, remotely is kind of the core part of it. Why actually virtual health and care plays such an important role? Where does this whole thing started? Well, as we said, this report was really born in the middle of COVID-19, which was essentially the time under which we have seen that, in fact, technology plays an even more crucial role than before. Even before pre-COVID times, there has been a vast adoption, and I would say quite a lot of different solutions being deployed in different areas of digital health. But what we see even more now is the need of integration, the need of really addressing traditional health and care in a new way through hybrid health systems. And post-COVID, this is a trend that came and stayed. Now, around the world, there have been startups, there have been established companies, there have been large technology players, there have been ministries, different parts of the ecosystem, I mean, different types of actors innovating. And within this innovation space for virtual health care services and solutions, this expansion, as you can see from some of these numbers, have been tremendous. The numbers speak for themselves. If you think that normally it takes several years for a solution of any sort of a digital solution or a service to get deployed, tested, and validated, now imagine that during COVID-19, we're talking about hundreds of thousands of increase of usage for just 2 years. And most of the data in this report is really looking at all the period between late September 2019 all the way until pretty much today. Now, on the same time, the role of technology is extremely important. That is, we all agree on that. We have all agreed on it also during COVID-19. However, it also put a little bit of a spotlight on where actually the divides are. Because except for having a number of different issues around addressing inequities on the delivery and access to health, there is also a huge divide in terms of different topics around age, around disabilities, access to different kind of health information services, depending on where the location of the respective population health group is, what is the income level, what are the social group types, and so on. And this discussion has really fueled a lot of the content behind this report. So there are a lot of social determinants of health which actually have been influencing, in a way, which are these new virtual health and care policies that governments should be really looking at in order to fully address topics around health and technology. And some of these have been really captured through this extensive landscape review that we have done. Now, we have spent time with the working group to really look at 23 different case studies of countries and really looking at what were the latest trends really on a policy level. We're really speaking specific regulations, policies, and global recommendations coming from in-country national policy frameworks. And what we wanted to see is the evolution of these policy frameworks. There were really a lot of differences because we have seen that some countries are faster than others. Others, I would say, potentially better in particular areas within these larger frameworks, but not in all. And so with our report, we wanted to create a little bit like a comparison, if you want, of what worked, what didn't work, how can countries learn from each other. Another interesting fact is that, in fact, it's not the high-income countries necessarily that had the best policy solutions when it comes to virtual health and care. It was, in fact, more the countries which looked at it holistically, really being able to address the inequities across a number of factors, such as the digital divide included. Now, in the following slides, what I wanted to show you is some examples, and this is really from the Asian region. If you go to the report, which has such a vast variety of information from the countries, you can see that, for example, unfortunately, in some countries, this maturity in terms of existing policies is not very high, but in others, there are specific initiatives that are truly exemplary. And I wanted to pick a couple of examples, and together with our speakers today, later on the roundtable, I'm sure we can go deeper in this. So for example, we have seen that one tremendous example came from India, which is the #1 most used around the world solution, digital solution, Arogaya Setu, which was a mobile app to do contact tracing during COVID-19. And already back in 2020, it had over 200 million users, which spoke about the speed in which an innovation like this had reached really the people that need it the most. Another example of an interesting policy that was implemented in India came also thanks to the work, again, with the private sector, which is actually connected to the work of the Apollo Telehealth network. So Apollo hospitals are the largest Indian telemedicine provider, their private hospital network. They have a number of virtual health and care services, but they were also the first ever organization in the world to attain a certification for ISO, which really could guarantee not only that they could deliver these services, but that these services have the same level of safety and quality as them being delivered in person in front of a real practitioner. So this is one very extremely strong example from India, and I'd love to hear from our speakers what else is really the latest there throughout the 2022 period when these policies have evolved. But really, India is one of the best case studies of how these policies have been put into day-to-day use by patients and by providers and policymakers all at the same time. Another interesting example on actually how do you test policies and how do you actually test innovations came from Singapore. Because there, the government helped, thanks to a public-private partnership, deploy a regulatory sandbox where interesting solutions and services could allow for licensing, experimentation, and adoption. This, in other words, means that if you have an interesting telemedicine service that you want to test as a provider, then you have the chest ready to go to a safe environment, and you can prove that your service has high level of quality, reliability, and really satisfies these needs around licensing, around regulation, and also allows for capacity building. Because during COVID-19, obviously, people couldn't just meet at the same place. So even the capacity building element was extremely embedded inside of the policy element. Another interesting regulation from there, of course, connected to this first one, is the opportunity to directly share health data, which is also a very important topic, I would say, around the world. Really, the latest best practices around data sharing between service providers, between the public system and the private system, and even between countries. Further down, again, another example from Bangladesh, from where I'll be also very curious to hear from 2022, what is the latest, is really by the deployment of another extremely successful teleconsultation platform, which is run by the government, called Shashto Bataillon. And even before the pandemic, it had a very, very big success, and it speaks for itself. 6 times more people were using this service virtually and getting their home support, the care outside of hospital walls. And further solutions like this were deployed throughout the year, and I'm sure our speakers are going to share a little bit more about that. Now, in one of the countries where I'm personally currently engaged with, because together with the government of Vietnam, and more specifically the city of Ho Chi Minh, we're working on actually deploying a virtual health and care service today, not related to COVID, but related to cardiovascular population health. I can tell you from personal experience that there is a huge evolution when it comes to the thinking about the role of integration of, I would say, different types of solutions and different systems to manage data and to manage cases from patients into really a full and integrated model for health delivery. And so Vietnam is a very good example, because in the past there was quite a lot of disintegration, or I would rather say really fragmentation, when it comes to systems for virtual health, and also when it comes to different services which could be deployed. But this is changing quite a lot. And so these are just some nuggets, I would say, of examples from different countries. What is going to be more interesting is to talk about why some of these picked up and why some of these didn't, and specific to the Asian region, which are those examples which could be leveraged across the board, both in terms of practical policies, but also examples of data and technology solutions which really made sense. Now, when we were working on this report, what came out of it is ultimately 15 essential elements for virtual health and care policies. And they covered a large spectrum of topics, all the way from reimbursement policies to interoperability, to innovating through new business models and digital solutions, to governance, to shared responsibility on licensing, a number of different items. And these 15 different elements were clustered in 6 main pillars, if you want to call them like this. If you recall from the previous report on AI in health, these are exactly the same pillars. In these 6 pillars, we're looking at 6 areas of impact. And often when people ask which area of impact we should start with, the answer is not pretty straightforward, because you have to work on almost all of them, almost in parallel, if you wish, if you want to see that there is a really long-term impact to the health system in terms of raising maturity about virtual health and care in the day-to-day world. Now, if we look a little bit at the details, these 6 areas cover the work around data and technology, which is, of course, a key piece of the puzzle, around governance and regulatory, which is, for us, one of the main points of this particular report, really the frameworks, the people in the workforce, which is the need for capacity building and even creation of new type of jobs, which didn't exist in the past, ensuring that the different groups within the health system have the right kind of skill set to deploy and to manage this kind of virtual health and care services. But then, of course, the right kind of partnerships have to be built, the right kind of business models, often relying on public and private partnerships. And last but not least, and extremely important during COVID-19, the topic around human-centered design. Or in other words, how do you create virtual health and care policies and the related to them services that are deployed, which put the patient in the center, which put ultimately the end beneficiary in the center of the design. Not only the design in the sense of deployment, but design in the sense of conceptualization, testing, validation, future proving. So these 6 key policy pillars are the building blocks of this report as well. And what we came up with is really a set of recommendations for the different stakeholder groups to bring back home. And again, we won't have probably time to go through all of them, but really they cross the whole span between these 6 areas, cover a number of things from, I would say, more ground infrastructural, more foundational type of work, all the way to the more innovative work, which goes to really help take innovations for virtual health and care, innovative platform models for businesses, collaborating also with the public health systems, different kind of workforce initiatives, and encouragement, of course, of involvement of different types of populations in the co-creation process, and models for innovative financing, so that these really initiatives and policies could be sustained in the future. I would invite you really to have a look at the call for action for the different stakeholder groups with which you engage with. But what is a key point to all of this is really that it's a question of demand and supply. And we have seen that, unfortunately, during COVID-19, we didn't have much of a choice. So the demand was there. All of us needed to make sure that our loved ones and ourselves really have access to health services, and then good quality of health services, safe health services, and the right kind of health services at the right kind of place and time. And this is really, I would say, the call for action to build trust on all the levels of the ecosystem, and engage the different kind of partners and actors, so that these different policy initiatives and the resulting from them specific actions, depending on the stakeholder group, actually could be deployed and could be adopted with the right kind of trust. Now, the future calls for one thing. It calls for thinking of how can you do things building on what already exists? How can you improve on what already exists? And this is where we're going with the virtual health and care services as well. We believe from the working group perspective that the future is really a complementary future in which there is a hybrid continuum of health and care delivered in person, but also virtually online. And this is really a future-looking, inclusive policy making. And it's not just policy making for the health sector. In fact, it's a policy making spanning across a number of different policy areas, from all the way from educational policies to technology policies, and so on and so forth. So it's extremely multidisciplinary because of the nature of the connections between virtual health and care services and its dependence on key technology infrastructures, but it's also because it highlights where some of the big inequities are and what actually the different stakeholders can do to address some of the inequities, which also could have been slightly more highlighted during the pandemic. Now, big thanks again to the whole working group that made actually this report happen, and specifically the HJE Health Information Network that's been always like a key contributor to this thought leadership piece. And with this, I would guess I'm more curious now to hear the second part of our meeting and learn a little bit more on where are the current trends from the countries, where are the biggest challenges, and handing over to you, Jake. Thank you.
Thanks a lot, Lucy. I think it's a great justice that you have done to summarize a 200-page report into something like 20 minutes. That itself is a great achievement here. Thanks, Lucy, for that. Let's move into the interactive part with our panelists. I think I would like to take Bangladesh, Dr. Fatima first. Dr. Fatima, I remember Bangladesh had released the Medical and Dental Council had released the telemedicine guidelines, I think in 2020. And then have there been any other policy or regulatory frameworks that have come? And then the other question is what is the current state of telehealth or the virtual health services in Bangladesh? What has been the acceptance or the impact? And then do you see a better equity has come in place right now from what it was during the pre-pandemic days? Thank you. Over to you, Dr. Fatima.
Thank you, Jay, and good afternoon, everyone. This is Fatima from ICDDSB Bangladesh. I am working here as a facilitator of digital health. The things is the two questions. One is what is the status of the pre-pandemic and pandemic period, and what is the legislation and our strategy. So I would like to start with this telemedicine status in the country first. In Bangladesh, there is a government health system. There is a telemedicine, teleconsultation services. This name is Shastro Batayon. It means the window for health. It's established in 2016 in Bangladesh. And it was a cost is 3.6 Bangladeshi taka. It means a 4 cents. And it's any citizen can use these services for their primary health care. But when the COVID has hit in Bangladesh in March 8th, in the first cases, the government has decided to make it a toll-free services for all the citizens. So it is a free of cost. And previously, before announcement of the COVID, it was every day, every month, the call was 16,000 per month. And suddenly it has just raised to 60,000, and the next month in April, it was 125,000 per month. And suddenly this change, the telemedicine services and government Bangladesh needs to change its model. It is previously it was they deployed 20 doctors in a 3-shift, and they took 75 doctors. So the call rate has increases, and also the services for influenza-like illness, this type of care has increases. The things is we analyzed the data pre-pandemic period and then the pandemic period for 4 months. And our team also analyzed the data previous 2 years. The things is when the COVID hits to Bangladesh, we see that the influenza-like illness and care seeking has increased, and as well as other diseases like your diarrhea, the complaint of joint pain, complaint of any generalized illness, and also for enteric fever, obstetric and gynecological issues. This has also increased from 2 to 6%. So other care seeking has increased, And as well as we can see that previous year data, we can see that the referral was 2%, and in pandemic period, the referral to higher facilities were 4 to 5%. It means that previously for telemedicine services, people use for primary healthcare. And during the pandemic, people also use for primary healthcare and also the emergency basis, because referral proportion has increases. This is the one changes we have observed. And other issues is for that, if we have another project. This is like a service data, what I said just earlier. I had one research project to look at like 3 days follow-up for the influenza-like illness or COVID confirmed patients. And we found that the COVID confirmed patients, they are aligned with their doctor's consultation and their advice, and people are happy because of during the lockdown, they can use these services at home and get referral or information. Then how can they get for the services? And the next question about the legislation. Actually, Bangladesh Medical and Dental Council, they have a launch a telemedicine guideline 2020 after this pandemic, because not only the government service, we have a private hospital and also service provider like a Telenor in Grameenphone. They have a services for telemedicine services very long ago, before established from like 2010. It was like 789. You can call to 789 and get a doctor. It's like 10 years. These services have also increased, but in BMDS telemedicine guideline has established in 2020, and in Bangladesh government, like telemedicine service and Ministry of Health and Ministry of ICT, they have a digital health strategic plan for Bangladesh. It is 2021 to 2025. So it has everything in field, but we did not like tested the informatics maturity in Bangladesh, like all the modalities. Thank you. Did I answer your question or?
Yes, thank you, Dr. Fatima. I think you also, so from what you said, like it is clear that, you know, the acceptance in general for the virtual health services have really grown. And then also, you mentioned about the regulatory framework that was done in 2020, and I think in every country, usually, you know, these things change. Something is done during the pandemic because of a limited scope, or, you know, during the time like when people are not able to actually have the reach to the health facilities, and this kind of frameworks are created to make things more flexible. But then like over the years, they also undergo a lot of evolution. Thank you very much. I think
I have two other things to just add. I missed it. Actually, when we analyzed the data, we found that previous 2 years data, we found that male person, educated person, and people from urban area, they call more for telemedicine services. But during the pandemic, this trend is same. I mean, male person, people who are educated, who lives in urban area, they call for seeking care through telemedicine. So trend has not changed. Call number has changed. So we have to like develop a communication strategies. Like it was our one of a recommendation to the government, like we have to increase our communication strategy through health ministry, through education ministry, and other ministry like agriculture ministry. Like how can you get teleconsultation services from the government with a very low cost or free of cost? Thank you.
Thank you.
It's like a digital divide exists in country. Women doesn't have empowerment or doesn't have like a capacity to call for national teleconsultation services.
This is a very important finding also, because like when we talk about the Broadband Commission report, we also talk about the equity. So that's very important. So thanks for sharing this. And I think let's move to Dr. Sanjay Sood from India. Dr. Sood, like eSanjeevani telemedicine, national teleconsultation service has been case study for almost everyone right now. So could you please share like how has been the growth of the national teleconsultation service? Like I am aware that it started even before the pandemic, but then during the pandemic, the service was very well accepted, like pan India, and then like what are the plans next? And then also, like, what do you think in terms of the support of compliance to standards, as well as like also the evolving policy and regulatory framework in India? Thank you. Over to you, Dr. Sanjay.
Thank you, Jay, and good day and good evening, everybody on the panel and attendees. Well, as Jay, you mentioned eSanjeevani, the National Telemedicine Service of Government of India, which is in a way being taken care of by us at Center for Development of Advanced Computing here in Mohali, the northern part of the country. We put it together and it has shaped into a mammoth telemedicine platform, which is, of course, a cloud-based telemedicine service, and it has evolved into a system that is capable of hosting or supporting more than 1 million teleconsultations every day. And we've already served over 60 million, around 60 million patients in less than 3 years. And the platform is accessible through over 100,000 health and wellness centers in the country, which are located in the rural areas and remotest of the parts of the country. And we are also supporting or hosting over 1,100 online OPDs, which are accessible or which are serving patients who want to directly consult with the doctors in the confines of their homes. And this entire network is being sort of served by over 200,000 doctors, who are doctors as well as the community health officers who are serving the populace. And the best part is that it has been equally embraced by or adopted by doctors as well as the doctors as well as the patients. And various provinces in the country, or the states as we call in India, they've come forward with numerous numerous processes, enhancements and innovations which we are putting in place with their support. And this is all empowering patients as well as practitioners. And some of these include, enabling the doctors to prescribe medicines which are available in the health centers from where the patient is consulting the doctor. So that helps the patients to get medicines the right way. So we've integrated eSanjeevani with lots of other similar healthcare IT applications which are there in the digital health ecosystem in the country. And accordingly, we are also making innovations, or rather, working on processes which are enabling the transmission of health parameters wirelessly from the patient to eSanjeevani and then to the doctor. So we are trying out various diagnostic devices, and the diagnostic devices which are capable of running point of care tests or rapid diagnostic tests. And we are integrating them based on the needs of the states or the provinces. And we have around half a dozen of these devices. Those have been integrated and they are operational in various regions as per the requirements of the states. And besides this, I would say telemedicine has been a runaway success in the country. And considering the benefits or the potential that telemedicine has for the populace in a country like India, which is huge, vast, and then there are lots of majority of the population is living on the darker side of the divide, and telemedicine really is plugging or is bridging this divide. And as a result of which, telemedicine based on the eSanjeevani experience has evolved into a domain where the specialty telemedicine networks are also coming up. We've already set up a specialty telemedicine network in the domain of tele-stroke management in the state of West Bengal. And we've also put in place a telenephrology telemedicine network. And these two networks being specialized networks, we have a tertiary level super specialty hospitals. One is centered around neurology, and the neurologists are serving the district hospitals, the patients as they walk in with some ailments pertaining to conditions pertaining to kidney or strokes, etc. The CT scans, etc. are immediately sent to the hub where the nephrologists as well as the neurologists, whichever specialties specialists are required, they assess and immediately address the requirement. So this way, I think telemedicine is growing to sort of touch many specialties. And very recently, we've rolled out another telemedicine network. It is a specialized telemedicine network for people living with HIV/AIDS. So that has been conceptualized in collaboration with National AIDS Control Organization of the Ministry of Health and Family Welfare. So with these kind of interventions, we can say it is growing rapidly. And as Lucy mentioned, private or the corporate healthcare sector is also using telemedicine, and lots of patients are coming forward for these virtual consultations. And we can say that in times to come, we will have a huge digital health ecosystem in the country. And as far as the regulatory aspects are concerned, I would like to mention that in India, we have Ayushman Bharat Digital Health Mission, wherein the efforts are on to ensure interoperable digital health ecosystem in the country. And almost all the healthcare IT applications are now working towards compliances which are laid down under this particular digital health mission, and wherein the practitioners, the health facilities and the patients, they will have their identities, and they will be able to exchange health records wherever the patient might be, wherever the doctor might be, or whichever hospital or the health facility the patient might be visiting. So eSanjeevani is already complying with this kind of requirement, and as a result of which we can say that the telemedicine applications are interoperable, getting more and more interoperable, and they'll be able to talk to each other with the central repository of health records, which will be maintained nationally. And besides this, the National Medical Commission in the country is also working towards putting in place the professional conduct regulations, which will certainly, for the doctors, of course, which will have a far-reaching impact on the way doctors practice in real as well as in virtual environments. And then besides this, we are also, pre-regulatory stage, we are also exploring the possibilities of applying the WHO and ITUs have framed the global standards for accessibility of telehealth services. So we are in touch with them. We are discussing with them the modalities to get them implemented and tested in a platform like eSanjeevani, which is a huge platform, and on daily basis we are serving over 250,000 patients. So we intend to test these, implement these global standards for accessibility of telehealth services for specially abled people. And once these experiments or these tests are done, these standards would certainly again become a part of the regulations which are in place for telemedicine. And in 2020, India had come up with the telemedicine practice guidelines, and now these are under revision. And very soon we'll be having the second version of telemedicine practice guidelines in the country. Thank you very much. In case you would have any queries, we'll be happy to address them. Thank you very much, Jay.
Thank you, Dr. Sood. This is very comprehensive state of virtual health services in India. Thank you very much for that. I think probably there will be some questions from the audience. Maybe we can, because you answered almost everything what I asked and probably more. So we will wait for the questions from the audience towards the end. I think we will now move over to Indonesia. Mr. Patita, do you have any stories about differences of telehealth implementations before and during pandemic in Indonesia? That is one question. And then the second one is, what are the expected contributions of the upcoming regulatory sandbox to scale up telehealth in Indonesia? Because I have heard about it, just more of a news article, but would like to hear from you firsthand. Thank you very much.
Yeah, thank you, Jay. Good evening, everyone. Yes, the difference about the perception about telehealth pre and during pandemic in Indonesia is actually quite contrast, because pre-pandemic, the telehealth focus mostly from the government side is mostly from healthcare facilities to healthcare facilities, not from healthcare facilities directly to the patients. And for the healthcare facilities or the telehealth providers, it mostly done by the private sectors. So during the pandemic, it merged. So the government actually collaborate with 17 of telehealth providers to connect with the confirmed COVID patients to get the teleconsultation, and then we send the medications to the patients who undergo the quarantine, and it's all free of charge. And we also see the massive rise actually of the telehealth consultations before and during the pandemic. At least for this year, we already recorded about 12 million visits for the telehealth only the first half of this year. As for last year, I think we reached about 11 to 12 million, 11 to 12 million for the whole year. So the difference actually a positive one, because the citizen see the importance of telehealth again, because they're afraid to go to the hospital, and the healthcare facilities also almost overwhelmed by the patients. So actually the government also pushing the usage of the telehealth that provided by the private sectors to reduce the burden of the healthcare facilities. It started at the end of last year, and we saw like the increase of usage starting the end of last year. And through this year, we are at the moment at building our practice guidelines for telemedicine in Indonesia. And parallelly, we are also preparing the regulatory sandbox as you asked before, because there are several things that we would like to address. And from us, Ministry of Health, of course, we focus on the permits of the platform of telemedicine. And then we also collaborate with our Medical Council of Indonesia, where they focus more on the competence on the health informatics of the healthcare professionals. And then for our national insurance, they focus more on the payment side of the telemedicine. So our regular sandbox is actually try to cover all of the bases about the telemedicine, because it's not only about the technology, it's not only about the healthcare, but it's also about raising the awareness to the patients, raising the competency of the healthcare professionals, raising the awareness about the payment scheme for the telehealth, and also we are trying to we try to reach people that not usually get the healthcare facilities by we coming to them first. So we are coming to them, not they coming to us with the when they're sick or they need healthcare services, but we coming to them and we do the screening using telehealth as well. So we will also shifting our effort not on the curative and rehabilitative, but also the preventive and promotive of the lifestyle. So yeah, and this effort, hopefully we will start the regulatory sandbox within this year. On the fourth quarter of this year, we are preparing the regulations as well as the guidelines of the regulatory sandbox, and we focus one of the main priority, of course, of the telehealth. And as I mentioned before, we will focus on the competency of the healthcare professionals about the payment scheme, and also, of course, about the standard of the technology and data for the telemedicine platform. I hope it answers your question, Jai.
Yes, thank you very much. It's very interesting to know that. And then also, like, I think we will move to Malaysia next. I think because they are also working on regulatory sandbox with respect to the online health services. We have Dr. Fazila here, and then also like Indonesia, Singapore, and Malaysia, as well as to some extent like India also, like all of them are working for regulatory sandboxes. So like we could see some synergies in the discussion here. Like let me move to, thank you, Mr. Tambonan, and then let's move to Dr. Fazila. Dr. Fazila, are you there?
Yes, can you hear me?
Yes, it's very interesting. I remember way back in 1997, Malaysia had this Telehealth Act. It's very interesting. Like you are a pioneer on that. So your country was far ahead when others were still, maybe starting the telemedicine services. Like you had a Telemedicine Act way back in 1997. Has there been any further regulatory or policy developments in the country of late? That's one question. And then like, what is the kind of acceptability or impact of virtual health services pre and during the pandemic? And that's my second question. I'm also adding one more. That's the last one is like about the regulatory sandbox in Malaysia that's focusing on all online health services in specific. Over to you, Dr. Fazila.
Thank you. Good evening, everyone. Thanks, Jai. Oh, yes, we had Telemedicine Act 1996, 97. That was the era where we moved into like a digital economy kind of era at that time, you know. So we started with the Telemedicine Act because we had the National Telemedicine Services. But it was very targeted. It was mainly provider to provider, mainly in 4 areas: cardiology, radiology, dermatology, and neurosurgery. But you know, at that time, it was an old architecture where you have dedicated line, huge equipment, dedicated room, I mean, at that time, mobile was not really used. So we had an act, but somehow the act was never enforced. And in 2019, we decided to repeal the act, where we thought that there are many things that is no more, it's already an old act. You can't use that act anymore. But however, you know, the National Telemedicine Services, it took almost 12 to 15 years before we decided that it must stop because it's obsolete, the architecture is old. And then in late 2000, you start seeing provider to patients. Telemedicine is done by healthcare providers, but very ad hoc manner. It was not a national service done by hospitals, public or even private hospitals. And the uptake before the pandemic, of course, was not much because of also, I think, is the Medical Act, where the Code of Conduct says that you must see the patient, you must examine, or you must establish a relationship, patient-doctor relationship. So a lot of the telemedicine or virtual care was happening for follow-ups, not really new cases. And then what we started to see, interestingly, is 2015, 2016, startups start mushrooming, giving virtual care solutions. But these startups are not regulated by Ministry of Health. So where a lot of services provided to patient is given through a platform. So then we started to see the platform economy coming in. So that's when we decided that, you know, we really need to do something about this. So in 2019, that was way before pandemic, we visited Singapore. We saw their LEAP program. I think Singapore is online. They can also mention about their program. And that's, we decided, we really have to do something about it. And then the pandemic hits. So what happens during the pandemic? Everyone went virtual, you know. So actually, it is the pandemic that accelerated the whole thing. And at that time, the Medical Council also relaxed the act, the guideline, and said that you can see patient for the first time online and so forth. So the whole acceleration of telemedicine really heightened up during the pandemic. We even had a COVID assessment center online, Then of course, with new emerging technologies, mobile technology, new platform, new solutions out there, this is very much easier. And we also, during the pandemic, we improved a lot of our connectivity, infrastructure, and then later the broadband became an utility. So that was also actually accelerated the use of telehealth. So in 2020, we had a consultancy. We came up with a regulatory framework. How do we govern these startups or this platform economy? and how do we protect both providers and also the patient, and without compromising quality and safety, and of course confidentiality and privacy. So that's when we decided that we need to do a regulatory sandbox. So today we already started a regulatory sandbox. We started about 3 months ago. So far for the first cohort, we have about 30 companies, 30 startups companies who are already on it. We have come out with the first draft of a new telemedicine or virtual care or virtual care guideline. So this will be the basis where we will, together with the startups and the industry and also the providers, design or co-design new guidelines for the future. But of course, the first guideline, the first version is using the existing act and all the act and regulation. Definitely, this has to be improved. So the entire regulatory sandbox is about 2 years. It should end next December, but we are hoping by this December we will have a kind of the first new version of the telemedicine guideline. Together designed and co-created with the industry. So that's where we are today. Definitely this telemedicine is rapidly growing, and I think it will reach about 30 to 40%. I'm expecting 30 to 40% of our care in hospitals or clinics. So moving forward, it is beyond the walls of our hospitals and clinics. So we are really looking forward to have a new guideline coming up soon. Thanks, Jai.
Thank you, Dr. Fazila, for the update about the regulatory sandbox, as well as eagerly looking forward to have a look at the telemedicine guidelines that's coming up. So let's move to Philippines. Dr. Eric Tayag is here. Dr. Tayag, this question is for you. I remember, I think around maybe June or July 2020, we had the practice guidelines being released by the Department of Health. Like, have there been any further updates to that? And then in general, like, how do you think the virtual health services in the country has been accepted, and what has been the impact? Could you please share that, Dr. Eric? Thank you.
Thank you, Jai, and good evening, everyone. This is Dr. Eric Tayag from the Philippines. Our journey in virtual care or telemedicine has started since 2002 with the UP National Telehealth Center, and it came into fruition in the last decade when they introduced biomedical devices, linking it to the patient, transmitting data information, and offering telemedicine consultations from specialists at the Philippine General Hospital, precisely to improve maternal health and newborn care in the Philippines. And the target locations were what we call GIDA, or geographically isolated disadvantaged areas. So they collaborated with the Department of Health. We had some hiccups implementing the system. So the Department of Science and Technology came to the rescue to fix it. And then the pandemic happened, which was a silver lining, because what we were attempting to actually improve the patient experience on telemedicine became a reality in this pandemic. It started as a DOH COVID-19 hotline, offering information services on COVID on a 24/7 basis. And then it evolved into a telemedicine platform, initially as a Jophony. And then we had to do sandbox on third-party providers of telemedicine, Jai, because the demand was so great. And so we have now 11 validated third-party providers, and they are on a subscription basis. And then we had to roll it out and scale it up for health facilities and local government units linking it to existing electronic medical records. So we have different platforms. There will be those with no gadgets, just consultations. There will be those that have remote capacities for using certain equipment. So it's a varied universe of telemedicine in the country. We have issued policies that would guide practitioners on the practice of telemedicine and allowing them to provide e-prescriptions. And also we wanted to monitor and evaluate the system. Right now, we are going to issue a manual that provides the standards for the practice of telemedicine in the country, clarifying which behaviors are not acceptable. And this will be guided by a code of ethics from the Philippine Medical Association and the Professional Regulation Commission. The code of ethics is very important because we believe that not everyone can be a telemedicine provider. In the country, only physicians are allowed to practice telemedicine, although we get reports that other professionals are into telemedicine services, and we have to actually remind them that this is not possible at this time. The PhilHealth, that's the social health insurance corporation in the country, as we have been advocated with them so that they can include this in the benefit package. And so they had a pilot. This is for the COVID-19 home care package, and in which telemedicine is included among the services in this package. Right now, telemedicine is not only for COVID cases, it's for non-COVID cases. And we're happy about the results because the continuum of care, because services have been disrupted, has been refocused on chronic diseases, follow through. We also have this policy that there should be at least a face-to-face interaction between the patient and the provider, but this is not absolute. So we still allow telemedicine providers to use audiophony or other virtual platforms. And because many of the telemedicine providers use social media platforms, we still allowing them, but we have cautioned them that in the coming months that this will not be allowed anymore when we release new policies regarding this. And because of our experience, we were able to provide and actually demonstrate best practices. And we shared this in the APEC and the ASEAN meetings so that we can tell them what we have learned so far, the experience, and the purpose is to improve it further. And so telemedicine has a greater impact in this COVID, and we hope that it continues because, you know, if this is just a fad, then we will go back to where we started before the pandemic. But the signs are very encouraging that people are culturally accepting that telemedicine is one of the options they can have at this time. Over to you, John.
Thank you, Dr. Eric. It is very heartening to know the growth and then the positivity or confidence, I would say, that you mentioned, the kind of acceptance that is coming in. And then also like glad to know the guidelines on standards is going to be in place very soon. So wish you the best, and then like look forward for further updates from you, maybe sometime very soon, because there could be other opportunities for us to share the updates. This is just a beginning. This webinar is just a beginning, and then we will have more opportunities to know the developments in the region. Thank you, Dr. Eric. I think we will move to Singapore now. that question is like, how has the telemedicine landscape in Singapore evolved in the last few years? And then what was Singapore's experience in applying the licensing experimentation adaptation program LEAP, regulatory sandbox, to virtual healthcare services? Because I remember at least a couple of countries have taken LEAP as their benchmark and then been collaborating, or in some way that they have been actually looking up to the work that is being done in Singapore. So over to you now, Mr. Weng.
Yeah, thanks so much, Jai, for the kind invitation for Singapore to share this platform, and really happy to hear all the insights from the prior experts that have spoken before me. So let me just try to keep this short and sharp. But I think essentially in terms of the telemedicine landscape in Singapore, I think as with several other countries, like for example in Malaysia, like what Dr. Fadila mentioned, prior to COVID-19, actually the take-up of telemedicine has been generally quite low in Singapore in terms of a provider to patient type of telemedicine or teleconsultation services. I think similar with several other countries here, a lot of the telemedicine was provided more in a collaborative manner between healthcare institutions and clinicians, where we would what we call telecollaborate, right, to discuss on cases, and to, as part of team-based care, for instance. But and that one of the reasons why this was so was probably because Singapore, as a very geographically small nation, accessibility to care was, I would say, perhaps less of an issue in our context, where you have primary care facilities and acute hospital facilities, which are really not too far away from where our residents actually live. But I think all that really changed when COVID-19 struck, and with the introduction of safe distancing measures, and the general fear that people have to really leave their homes to visit healthcare facilities where COVID-19 infection rates were high. And that was when actually telemedicine services started to pick up. And at that point in time, the concern was that actually pre-COVID, the understanding of telemedicine was on both the providers and patients end were actually quite low. So even in general medical education, whether it's undergraduate or postgraduate in Singapore, the emphasis on the use of telehealth or telemedicine has been fairly low. And there's no dedicated modules or training for healthcare professionals to actually offer telemedicine safely. And I think that was one of the reasons why similar to Malaysia, where we actually observed there's a increase in the uptake, not the uptake, but the increase in the number of startups and private sector telemedicine providers who started or who were keen to offer telemedicine services to patients. And that was when we realized that actually something needed to be done, as we really didn't understand the risks that these providers that they actually brought about. And also because telemedicine was not regulated under our prevailing laws, because our previous Private Hospitals and Medical Clinics Act, which was enacted in 1980, actually focused a lot on brick and mortar premises. And with digitalization and COVID has shown us that a lot of services have now gone virtually and remotely. And that's also one of the reasons why we have opted to shift to a new Healthcare Services Act, where we go on a services-based regulatory approach rather than a more premises-based approach. And so I think with all this in mind, actually, we realized that, and actually some of these startups were very keen to work with the Ministry of Health, because they wanted to know whether their business model could actually survive, or they wanted to know what was the regulatory thinking behind telemedicine. And in that sense, they wanted to get first mover advantage. And that was when we realized that in order to understand the risks and also to co-create mitigations with the industry, an option was to actually go on a regulatory sandboxing approach. I think one, it provides a safe space for telemedicine providers to innovate and trial out their business models. And from a regulator's perspective, we have the assurance that we can put in place certain requirements for being part of this sandbox. And that gives us some assurance that the services offered would meet minimum standard of care. And so the selling point for the providers was that, this is something that you can work with us to shape future regulations, and you get a chance to then operate in a safe space and innovate. So I think that was the selling point of our sandbox. So I think through our sandbox experience, and with the COVID pandemic that came subsequently, it was quite fortunate that we actually did the sandbox early in 2018, because when the pandemic actually struck, what we realized and what we were able to do was that we were able to tap on those prior partnerships and relationships that we had forged during the sandbox days, and could quickly activate private sector capacity to actually help with managing COVID patients remotely, eventually setting up a home recovery program to decant COVID cases from the hospitals and our institutions and facilities back to home for less severe cases. So actually, I think the sandbox was, on hindsight, it was fortunate that we actually embarked on that journey, so that we could actually leverage on these networks and partnerships very quickly when the pandemic struck. So I think also, in terms of the sandbox in itself, I mean, we have closed the sandbox since last year. We took about over 2 years, or more than 2.5 years, to collect about 40 to 50,000 points of data. And I think that the results actually show that, in general, I think telemedicine providers are capable of seeing acute conditions, simple acute conditions, or simple, stable chronic conditions, relatively safe. And generally, providers are able to escalate certain cases which require in-person consultation, or where there's a need for emergency department referral. So I think that experience has shown us that we do have some confidence in our providers. But I think also in terms of what then happens after the sandbox, right? Once the sandbox, so that's probably one of the questions that a lot of people ask us. And I think where we see it is that the sandbox, with its insights, we can actually then use the insights to actually, ensure that our healthcare professionals and patients themselves are able to better understand the risks of telemedicine, when to use telemedicine for what type of conditions, and more importantly, know when telemedicine is not suitable for their conditions. And eventually, our approach is that with the sandbox findings, and also with discussion with our various stakeholders, from our healthcare providers to patients to telemedicine platforms, the idea is really to start looking at how we can better regulate and license telemedicine providers in this space. I think several of the issues that were mentioned earlier, including whether or not our healthcare professionals actually are qualified and sufficiently trained to actually offer telemedicine services, was another critical aspect that we found that we needed to address. And I think moving forward, we also do intend to impose certain qualifications and training requirements, right, for the medical directors or the clinical leads of our telemedicine providers, because they oversee the provision of the teleconsultation services for their licensee or their provider. And also for doctors that offer teleconsultation service, we do intend to also make it mandatory for them to actually complete specified telemedicine e-training to ensure, and also to have this on a recurring basis, maybe once every year or once every 2 years, to ensure that they keep up to date on the regulations that will be upcoming. Sometime, hopefully, we are targeting for sometime mid of 2023 to actually issue the regulations. And I think in the meantime, we are just really working through by consulting and engaging our stakeholders, really making sure that whatever that we put in the regulations would be really feasible from the operational standpoint, as well as at the heart of it is to ensure that safe telemedicine care is actually offered. So I think that's the long and short. I hope that's useful for everyone. So back to you, Jai.
Thank you, Weng. I think it's very good digest on the leap, because there has been a lot of interest from AHIN members about the regulatory sandbox in Singapore, and the leap has been an inspiration for several other countries as well. So I think that this topic as such deserves a separate AHIN hour, as we call our webinars from AHIN. Probably we will invite you again for that. Like we do have plans for having sessions on regulatory sandbox in specific to focus upon. So I think we would like to have you and your team there. And thank you, Weng. I think Dr. Narendra Kanal from Nepal was having some connectivity issues. I think he was not able to continue. But I could see Mr. Rajendra Paudal from Nepal. Rajendra, if you are there, like, could you quickly share those two questions? But then, like, make it please very quick. We just have about 4 minutes. Thank you, Raj.
Thank you. Thank you, Jai Ganesh. So regarding the telemedicine development in Nepal, in the regulatory part that we have got the telemedicine guideline just 2 years back that we have developed the telemedicine guideline and the SOP for that. And we have started a lot of telemedicine initiative to connect the rural villages with the broadband network by using the broadband wireless network. And the term telemedicine is quite, is a very quite expensive and very advanced systems. So we need to invest a huge money for bringing the network in the rural hospitals, equipments, and applications. So we have adopted a very simple systems since starting from the Microsoft Net Meeting to right now that we have used the open source, open meetings and other such type of applications. And we have not yet developed very own specialized system. But thanks to private sectors, the private sectors have introduced lot of tools during the COVID. They are able to connect with the people through the mobile app, and they could connect to the people to talk with the patient, and then they could advise the peoples about the medications and caring. So that was really happening very good in the major cities, but it's still large number of people are not able to access the technology, and due to the lack of internet connectivity, those peoples are not able to do. But Nepal government has given a high priority through the Digital Nepal framework. So there is a Digital Nepal framework. Telemedicine part is one of the highly prioritized projects, and government has allocated huge money to implement this. And this is the priority project for Ministry of Health and Populations. So we have two documents for the regulation perspective. One is the roadmap, the e-health roadmap, which have addressed telemedicine as a priority projects. And then we have got IHMIS roadmap, which is especially for integrated health information system. That has also prioritized the telemedicine systems especially for linking with the interoperability, because these telemedicine applications should be connected with the interoperability applications with the existing EMR systems. So that has been now, just now we are planning. So, and just this year we have completed the SOP. So there is long way to go, but we are now starting these things. That's all, Jai Ganesh. Thank you.
Thank you, Rajendra, for standing in for Dr. Narendra Kanal, and then it's been very helpful to have these updates from Nepal. Thank you very much again. I think over to Lucy. Lucy, I remember you mentioning about the work that you have been doing in Vietnam. Do you have someone to share those experiences before we close?
If we have a minute, so for sure. So deploying an end-to-end virtual health service, it's kind of a very big job. It's not something that can definitely happen over a day. And I think that it takes a lot of strong leadership from both city authorities and national level authorities to deploy that. We have seen such in Ho Chi Minh City, but it's also the combination of different technologies, pre-existing historical technologies, questions around fragmentation, as we mentioned, but also the novel technologies, combining I would say, the more classical types of tools, but also tools such as artificial intelligence type of tools, which we are using in this new virtual health and care service. And I can see now that you are now on the screen. Maybe just say 2 words from live from Vietnam.
Good evening, everyone. It's my pleasure to join this webinar. And I want to introduce Dr. Trường Nam, Deputy Director of the eHealth Administration, Ministry of Health, to have some updates on the Vietnam situations and policies.
Vâng, xin chào quý vị đại biểu.
Good evening, everyone.
Sau đây tôi xin phép được đại diện với Bộ Y tế được xin chia sẻ một số nội dung trong cái công tác chuyển đổi số và phòng chống dịch của Việt Nam thời gian vừa qua.
On behalf of the Ministry of Health of Vietnam, I would like to provide some updates on the eHealth in the pandemic situation and the orientation for the future development of virtual health.
Như quý vị đã biết thì thời gian vừa qua Việt Nam cũng là một trong nước mà bị ảnh hưởng nặng nề của đại dịch Covid-19. Trong 4 giai đoạn của đại dịch Covid-19 thì 3 giai đoạn đầu Việt Nam cũng đã có những thành công nhất định về trong công tác phòng chống dịch. Để thành công đó được thì đó cũng là sự áp dụng công nghệ thông tin và chuyển đổi số, đặc biệt là trong các vấn đề liên quan đến y tế từ xa, và telemedicine là một vai trò then chốt.
So telemedicine play a very important role in the pandemic control in Vietnam throughout the 4 stages of the process for pandemic control. So our achievement in the control of pandemic has great contribution from the telemedicine policies and programs.
Vâng, như quý vị đã biết là ở tại Việt Nam thì có một bệnh nhân người Anh là khi mà dịch Covid mới bùng phát là bệnh nhân rất nặng và nguy cơ tử vong rất là cao. Tuy nhiên, Bộ Y tế Việt Nam thông qua ứng dụng telemedicine hội chẩn từ xa đã cứu sống bệnh nhân người Anh một cách thần kỳ.
Our example for successful application of the telemedicine is that we have an English patient. It's the first case in Vietnam that has severe symptoms, and his life has been saved successfully with the contribution from telemedicine applications.
Vâng, bên cạnh đó thì chúng tôi cũng đẩy mạnh phát triển các ứng dụng trong hỗ trợ phòng chống dịch Covid, như là các ứng dụng về khai báo y tế, truy vết, rồi là nền tảng quản lý tiêm chủng và quản lý tư vấn từ xa, rồi là sổ sức khỏe điện tử của mỗi người dân có thông tin về tình trạng đã tiêm vaccine phòng chống dịch Covid hay chưa.
So in the pandemic, we have different networks using telemedicine and also virtual health. For example, the tracers systems, the health declarations, the vaccination management, and also the inform about the status of vaccinations and also stock of vaccine.
Để đạt được những kết quả đó thì chúng tôi có một số các cái chính sách và biện pháp để nhằm thúc đẩy trong việc chuyển đổi số, ứng dụng thông tin trong công tác chăm sóc sức khỏe y tế.
We have also issued different policies to support the telemedicine and virtual health in this period.
Các cái sự phát triển trong vấn đề chăm sóc sức khỏe y tế thì cũng nằm chung trong cái chính sách về chuyển đổi số của Việt Nam.
And this is in line with the government policy and strategy on the digital transformations for the economy and the health sector specific.
Về chuyển đổi số thì ngày 28 tháng 8 năm 2018, Thủ tướng Chính phủ đã thành lập Ủy ban Quốc gia về Chính phủ điện tử do Thủ tướng Chính phủ làm chủ tịch ủy ban, và nay thì gọi là Ủy ban Quốc gia về chuyển đổi số.
The government also established the National Committee for the Digital Transformation, chaired by a Vice Deputy Prime Minister.
Chính phủ cũng đã ban hành chương trình chuyển đổi số quốc gia đến năm 2025 và định hướng đến 2030.
The government also promulgate the national strategy on the digital transformations toward 2025.
Chương trình chuyển đổi số quốc gia nhằm mục tiêu kép là vừa phát triển chính phủ số, kinh tế số, xã hội số, vừa hình thành các doanh nghiệp công nghệ số Việt Nam có năng lực đi ra toàn cầu
We have also the roadmap to develop the different digital solutions, and also as the policy to support exportation of the product to globally.
Một số mục tiêu chỉ số cơ bản mà đặt ra là đến năm 2025, Việt Nam thuộc nhóm 70 nước dẫn đầu về chính phủ điện tử và kinh tế số chiếm 20% GDP, tỷ lệ dân số có tài khoản thanh toán điện tử trên 50%, và Việt Nam thuộc nhóm 40 nước dẫn đầu về an toàn an ninh mạng.
We set also the objective, the goal to be among 70 countries have the advanced technologies in the world and have a GDP with the national economy, digital economy of 20% of GDP.
Mục tiêu đến năm 2030, Việt Nam thuộc nhóm 50 nước dẫn đầu về chính phủ điện tử, kinh tế số chiếm 30% GDP, tỷ lệ dân số có tài khoản thanh toán điện tử trên 80%, và Việt Nam thuộc nhóm 30 nước dẫn đầu về chỉ số cạnh tranh.
We have also indicators in terms of integration of the Vietnam digital transformation into the world, and also set out the opportunity for getting the 50% GDP from the digital economy.
Hiện nay thì Bộ Y tế Việt Nam đang tập trung thực hiện 3 chương trình về y tế điện tử và chuyển đổi số. Đó là chương trình xây dựng cơ sở hạ tầng, triển khai thống kê y tế điện tử để từng bước hình thành trung tâm dữ liệu quốc gia về y tế.
Other countries will also set the goal in the health to invest in the infrastructure by specific programs, and also get ready for the database, the big data at national level.
Thực hiện hồ sơ sức khỏe điện tử, bảo hiểm điện tử, phần mềm quản lý trạm y tế xã phường thị trấn theo tiêu chuẩn.
We also develop the medical health records and also the management of the primary health care services at the commune levels according to national standards.
Xây dựng và vận hành hệ thống dịch vụ công trực tuyến một cửa của Bộ Y tế, kết nối một cửa quốc gia và một cửa ASEAN.
And we also step by step integrate our system into the ASEAN standard.
Về triển khai chính phủ điện tử thì hiện nay Bộ Y tế Việt Nam đã triển khai hệ thống quản lý các hệ thống văn bản điều hành, hệ thống thông tin quản lý điều hành 100% là trên môi trường mạng.
We also apply our e-government system in the Ministry of Health and in the health sector.
Bộ Y tế cũng đã triển khai cổng dịch vụ công trực tuyến và đến nay đã hoàn thành 100% các thủ tục hành chính của Bộ Y tế được triển khai trên dịch vụ công trực tuyến mức độ 4.
We also set the standards for the e-government in the Ministry of Health to improve the management and also the governance of the ministry.
Thank you so
Đây là
much.
những bước thành công mà ban đầu mà chúng tôi đạt được trong thời gian qua. Còn rất nhiều các cái định hướng và nội dung triển khai chuyển đổi số và phát triển ứng dụng thông tin trong y tế cho tới, thì cũng xin phép do thời lượng thì sẽ được chia sẻ nhiều hơn thông qua các cái tài liệu gửi cho các quý đại biểu.
So because of time limit, we provide some kind of brief information about the country situation and the Ministry of Health orientations, and look forward for further discussion with you and share other experience with you in the other events.
Thank you. Thank you, Dr. Nam, for joining us. It's a pleasure to have the EHA with us. Thank you. Thank you, Nam. I think we will close now. And then we do have a couple of questions. I could see one from Dr. Bunchai and then one from Lucy. Maybe we could take the question from Dr. Bunchai. Dr. Bunchai, you want to repeat it, or I think that question could go to Weng. I think that involves a bit of multiple information systems and probably like private sector engagement. Weng, could you take the question from Dr. Bunchai?
Yeah, sure. So
his question is how you integrate patients' data between different healthcare providers, facilities, if you need to do virtual care between different professionals and facilities. Thank you.
Right. Thanks for the question. I think that's a great question because one of the issues has always been interoperability between systems and how different providers can actually talk to one another and collaborate with one another, especially with moving towards team-based care. I think, especially during the pandemic, and the work for this actually had to start before the pandemic, especially within our public health care ecosystem. We have our integrated healthcare information system, or IHIS, who actually is sort of the IT agency for our public healthcare institutions. So they actually worked on a common platform in terms of the teleconsultation services that our public healthcare sector actually use. So in terms of that, it's then backed by this National Electronic Health Records, where we also have plans moving forward in the future to actually mandate a summary of health records for our healthcare licensees to be contributed to this central repository. And so that central repository, the NEHR we call in short, actually then serves as the common language in which any healthcare licensee can have access to that data for the patient that they see. So if a patient goes to private hospital A previously, and the records are then submitted to the central repository, if they turn up at a public sector or another private clinic, then the physician can actually refer back into the records. So I think we have started this contribution of data to the central repository on a voluntary basis today. Understandably, our public healthcare institutions are mostly on board, or in fact, all of them are on board. But of course, the private sector is the one that we need a lot of coercing and encouraging to actually get them on board, because one of the fears that they have is that, is the regulator watching me, right? If I then contribute data as a private provider, would you use that as evidence that, I have provided my services in somewhat unethical manner, or that we found fault. So I think that is work in progress that we really need to work together with our private sector, really convince them that this is really for the better good. At the end of the day, it's for care continuity, for better and more holistic care for patients. And on the flip side, we need to reassure them that medical legal liability for providers that actually contribute data will need to be addressed. I mean, some of the issues, we are in the space of consulting some of our providers, and some of the issues that they raise include with this mandatory contribution to the NEHR, or the central repository, is there then a liability for doctors to go back into the history of this patient through this central repository? And to what extent, how far should I go back in the history? 10 years, 20 years? Or if something goes wrong, then I will be faulted and taken to task. So I think these are some of the practical issues that when we are trying to facilitate this common language and data sharing, and to have that accessibility to patients' records in a more seamless manner, I think those are some issues that we ourselves are still grappling with. And I hope that answers the question. Thank you.
Thank you, Weng. I think it's a great answer. Dr. Gunchai, I hope we could also take this further discussions maybe offline, because since we are well past the time, I think it's time for sum up. And then excellent meeting you all here, and thanks for your time. For some of you, I think it's very late. So thanks for joining us. And Lucy, can we actually wrap up? I think I could see, like, from all the panelists, I could see some of the what they shared, like, actually corroborates the findings of the Broadband Commission report, like, the growth of virtual health services, especially during the pandemic, and then also the evolving space of regulations and policies that's happening everywhere, and then also this regulatory sandbox. And then I'm very impressed, like Weng also said, like, what do you do with regulatory sandbox after it's closed? Like, so that's fantastic. And thank you very much. And then Cha, like, can we have the closing slide with the announcement of the AHIN general meeting that's going to happen in just a month from now. So we have AHIN's general meeting that also coincides with our 10th anniversary. And that's going to be from 10th to 12th of October. It's going to be happening in blended mode. And the venue is going to be in Manila, Philippines. And then more information will be shared in our listserv as well. And then look forward for you to join virtually or in person. Thank you very much.
Thank you. Bye.
Thank you.
Thank
Thank you.
you.
Thank you.
Thank
Bye.
you all.
Thank
Bye.
you.